Okay, good evening, everybody, and welcome to today's webinar brought to you by the Orthopaedic Research and Education Foundation India through OrthoTV. And today we have the pleasure of having Dr. Samanto from Kolkata, who's going to talk to us, and he's going to take a session on how you read X-rays, especially during the DNB and MS exam vivas. It's going to start with initially some points, and then he's going to make it interactive to all the participants. So I think I'm really looking forward to this talk by Dr. Samanto, and over to him.
Thank you, sir. My regards to John, sir, my dear friend Janki, and all those who have joined. So but today we are going to discuss how to present the X-ray during the Viva exam, during the MS or the DNB, because there are certain protocols and the examiners sir will like to hear whether you are following the protocols, yes or no. They don't jump into diagnosis. They were not giving very extraordinary or atypical X-ray during the exam. It is all very typical. Probably you have seen during your 3-year course. Okay. So I am starting. Is it coming the full screen, na Janki?
Yes, sir.
Okay. So I think when you are given the X-ray, that the basic points that you should not miss is that they don't tell like this is an X-ray. Okay, they used to listen to that. This is a radiograph of this part. Then definitely mention that whether this is a radiograph of the mature or the immature skeleton. Then what are the parts seen in that X-ray? Then you go into the actual description of the part seen in the X-ray, and then finally you go and tell your diagnosis. So this is the way you have to say. Don't tell this is an X-ray and this is a fractured neck femur, like this way or this side. So first, suppose we are going to see this. This is a very common X-ray. Every time we are seeing every day in the rounds or even the casualty. So Janki, we can take somebody to join?
Yes, sir.
You can take
Yes, sir.
somebody.
We have yes, sir. We have Rajan as well as Proshanjit. So Rajan, you start with.
Good evening, sir.
Yes. Good evening, Rajan.
Plain radiograph of left hip with femur of a mature skeleton showing left hip with femur and knee joint showing a fracture shaft femur.
Okay, very good. There is no point in tensoring like the plain radiograph. You can tell like this is a radiograph of the left femur with hip and knee joint, showing that there is a fracture of the shaft of the femur. Okay. Then they can go on asking which type and whether you can whether this X-ray is sufficient, yes or no. Is the X-ray sufficient or you want to do something else with this?
Sir, I will go for lateral view will be better because the distal fragment is rotated, sir.
Okay. So basically,
yes.
Is that the only thing that you find inadequate in the X-ray?
It's sir, I think the others.
You want
there is some
X-ray to show you the pelvis with both hips.
Yes.
Okay, and the knee joint, yeah?
Yes.
So it's important that you see the joint above and the joint below clearly. And in the femur, you see the pelvis with both hips, because there's a reasonably high risk of a neck fracture. You could also have a pelvic injury or acetabular injuries, okay? So always get the proper X-rays in the initial radiographs that you get.
Yes, so that was the hint to you, Dr. Rajan, that whenever you see, suppose one single film of any fracture, then you can comment on that part of the X-ray, but the examiner will ask you whether you want to do something else. Because when fracture, transverse fracture in a shaft femur is a high velocity injury. So you must have the X-ray of the pelvis with both hips so that you don't miss the neck fracture, which is quite a missed injury. And you must have the orthogonal view of the other part of the probably this is not possible in a fracture shaft femur, but you must have a pelvic X-ray where you can see you are not going to miss any neck injury or the acetabular injury or a pelvic injury or the SI joint injury or the sacrum. Okay.
And also one more thing, what you see very obviously in this X-ray is you're seeing an AP of the hip and a lateral of the knee.
Yes.
Okay, so that is something which should give you a hint that this is quite a high energy trauma and there's a complete rotation of the distal fragment. Okay.
Yes. So that is a very good point that you must see that this is completely rotated more or less like 90° to each other. Okay. So you must check the distal neurovascular and all these ATLS protocol and whatever. This theory definitely you follow accordingly when the examiner is going to ask you. But whenever there is you see a fracture in the shaft of the femur in a skeletally mature young guy, you must have a pelvic X-ray. Otherwise, you are going to miss something. Okay. So similarly, suppose if any other anybody can join in.
Yeah. So there is Rupam Prashanjit.
Dr. Rupam,
Devdutt.
Dr.
Yeah.
Rupam Rai is also there. Dr. Rupam, can you join?
Yeah, he's here only, sir. Okay, Prashanjit.
Anybody who can volunteer. This is not an exam. This will just.
Sir,
Yeah.
this is plain radiograph
Yes.
Okay, I think
of a mature
yeah.
skeleton showing pelvis with both hip joint and proximal femur bilateral side with left side neck of femur fracture.
Yes. So you have rightly told that this is a pelvic X-ray radiograph of the pelvis. The plane, you don't have to mention like plane.
Yes, sir.
Okay. You have to mention like the radiograph of the pelvis.
AP view.
Of a mature skeleton showing proximal part of the femur, and where we see that there is a displaced fracture of the left side of the neck. Okay, because you see this is a complete displacement. Then the theory, the active can answer everything you know, that how you classify your femur neck fracture or how when to fix and what are the protocol and everything. Okay, so this is the way you have to tell. Then suppose you get this sort of X-ray. Anybody?
Yeah.
You can
Someone else, I think.
Because we'll be giving very common X-rays. Then we'll gradually go into the different subjects of the radiology.
Okay, so Vansu has also joined. Prasanjit, you start
Prasanjit,
with.
you can continue. It is similar to the primary one.
Radiograph of pelvis with both hip AP view and showing the dislocation of the right hip joint.
Yes.
With acetabular fracture.
Very good.
With acetabular fracture.
Yeah. So this is the way that you have this is the radiograph of the pelvis showing both hips with the proximal part of the femur, and there is dislocation of the right side. Okay. Then probably in the theoretical or when you go into the when they ask the questions like whether you can delineate the lines, you know that when we read the acetabular radiograph that they can ask you what is suppose if you can see my mouse over there, can you tell me which line this one?
This is the anterior column line, sir.
This is the iliopectoral line. Okay.
Yes, sir.
And then this line you can tell this the mouse where the mouse is going. This is the ilioischial line. Okay.
Yes,
Okay,
sir.
so this
So-
is the TR drop that you can see both the sides, and if you see the way how the anterior column and posterior column, if you join this from this acetabular the lateral margin to this here to the TR drop, that signifies your anterior wall. Okay, and when this line goes from here to the here, that signifies that the posterior wall. But you are not going to comment unless and otherwise you do have a very clear X-ray and displays posterior fragment. You should not comment. But mostly we find that this is this. If the hip is going this way, mostly it is with the posterior wall fragment and it is a posterior dislocation. Then the question is that suppose you get this X-ray in the emergency, what is the first thing that you check in your casualty? Somebody
Sanjeet.
who joined it is we have to interact because this is
Yeah.
like you will tell, then we will guide. Suppose you get this X-ray and the patient has come to you, what is the first thing that you check?
Sir, I
Distal.
will check the vascular distal pulses as
Yes,
it is
very good.
posterior dislocation.
So how often do the distal pulses have a problem in a posterior dislocation of the hip?
What is the first thing you check, Rohit? Suppose there is a knee dislocation, then the first thing you check your distal pulse. When you suspect, when you see this, there is a posterior dislocation, even there is not a wall fracture. Suppose there is a posterior dislocation of the hip. What is the first thing you check in the casualty?
So what is likely to be injured?
Sciatic
Okay,
nerve.
Subhanshu.
Yes, very
Subhanshu
good.
is written, sir.
Yes, very
Yeah.
good. Somebody has told like the sciatic nerve. Like you see there are the three things that you don't forget. One is the when you see the dislocation of the hip, first thing you check is the sciatic nerve. Suppose you see a knee dislocation, you check the vascularity. Suppose you see there is a supracondylar fracture in in a child, you check the distal pulses. Okay, obviously you check the neurology, but these are the first things that you don't forget, because here in a posterior dislocation is very rarely the vascularity will be in jeopardy. Okay, so the sciatic nerve comes first in the mind. That has to be checked and that has to be mentioned in your emergency paper, that you have checked that sciatic nerve is whether it is intact or there is some problem with that. Okay, so anybody can if, those who have joined, anybody can volunteer. I will ask the question, then you tell me what is the X-ray, what is the radiology.
Mm. Yes, Aswat.
So this is a radiograph showing pelvis with both hip with implant in situ on left proximal femur.
So what implant in situ?
FNS.
FNS. This is an FNS.
I think
Yeah, just join.
this is the
But he should know.
this is probably the first implant that you have seen somebody putting, some senior is putting in the your orthopedic department.
So the new lot hardly ever see this implant. They've forgotten this implant.
No, I think this
No,
implant
but they're commonly seen here, sir.
Yeah, yes.
Still, but
still people are doing this implant. This is,
okay, I think somebody else should
anybody somebody can.
Fuse. Will you help him?
Dynamic,
So what implant is this?
DHS with
With
ESP.
Yes.
TSP.
So
what
when
is
so the thing is that whenever you this is another one basic protocol during the PG teaching, that
Yes.
don't tell like you're the shorter form of anything. Okay, like TSP, you should tell like the trochanteric stabilization plate. Okay, so then the examiner will be happy. Anywhere. This is not the question of telling TSP or whatever. You better to you don't tell like the DHS. You better to tell the dynamic hip screw with plate. Okay, So this is, then the question will be coming, whether this implant is, in which case, probably you will use the trochanteric stabilization plate. Anybody can volunteer.
So I think
Lateral wall deficient less than 25, 20.
Basically, yes. If you go into the detail of that part, then it will be difficult to answer if the examiner goes into very deep into this thing. You don't mention like the lateral wall thickness or the first you tell very simple thing like your stable or unstable variety of the fracture. When there is a medial cortical deficiency, you know all the classifications that the commonly we follow in the trochanteric fracture. So you can tell that there is a lateral deficiency, the 20.5, the cortical thickness. But that time probably, this time probably most of the people will be doing the proximal femoral length. Now the question is that if you are still there do you think, suppose it is a post-op of suppose for 6 months, do you feel that anything is wrong in this X-ray?
Yes, sir. It
you
will,
will able to answer. Yeah.
will go into, sir, implant failure, sir, because the Richard screw is protrusing into the joints.
So what's that? Why is that an implant failure? Implant
Sorry?
is okay.
Later on, it may.
So has the fracture healed or not?
So, fracture healed, sir.
So why do you call it an implant failure?
Implant failure.
The surgeon might have put it like that.
No. Implant failure means there is some breakage or something is like that. Okay. If you see, you see the tip of the implant where it has gone. Okay. You see here, the fracture is probably you write it here.
Yes,
But
sir.
you see as the barrel probably has not slid properly, that's why if there is a collapse which has been meant for the trochanteric fracture, but you see now the top of the dynamic hip screw is beyond the margin of the femoral head, so it is now touching the acetabulum. Okay, yes or no? Agreed?
Yes, sir.
Okay, so somebody who told that this is an FNS, and I told you that this is a very gross mistake, because it is this X-ray picture is never anywhere close to the femoral neck system. Okay, this is a very common and basic implant. This is not only in the X-ray you will find, definitely it will be in the instrument table, and you have to read in detail the thread diameters, the port diameter, the barrel length, when to use the trochanteric stabilization plate. I am not going to detail of the theory part of the trochanteric stabilization plate, but you must know that where the trochanteric stabilization plate is being used. Anybody can volunteer this X-ray?
I think
This is
yes, I think Piyush will tell it. Yeah, he's having a Prasanjit or Piyush, because those having thesis over is Prasanjit.
Okay, I will guide you. Suppose this is a radiograph of the knee. Obviously, you can see that this is a skeletally mature radiograph of a skeletally mature person. And can you see something on the lateral femoral
This is
cortex?
a post-op
Yes.
radiograph of probably ACL reconstruction surgery.
Okay, so this what is this implant called?
Sir, endo button.
Yes, very good. It is the endo button. Okay, and you can also see that this is
Tunnel for wire screw.
this is a tunnel for the tibia. Okay, then there's something is going to, we also check in the lateral film that your tibial tunnel. Okay, this is can you see this mouse here? This is the anterior margin of the tibial tunnel, and this is the posterior margin of the tibial tunnel. So what you check that this margin of the tibial tunnel has to be posterior to the Blumenstadt line. Okay, this is the Blumenstadt line. Understood?
Yes, sir.
So this is the Blumenstadt line, so that the tibial tunnel has to be perfect. So in your Viva table also you will get the implants in your. Then the one simple question I will ask you, probably how the tibial tunnel has been fixed, how the part of the graft in the tibial tunnel has been fixed.
Sir, maybe with the bioabsorbable screw.
Yes, maybe with because you don't see any button over here, you don't see any pillar and post technique is here. This is radiolucent, so bioabsorbable screw has been used. Okay, very good. Now we are going to another one. Anybody can volunteer. So this is one X-ray, radiograph of the ankle. Can you tell? Because this is a very common radiograph. Okay. Anybody, please volunteer.
This is the fracture of posterior malleolus.
Posterior malleolus.
First, you tell about the posterior malleolus. Don't I tell you? So I told you in the very beginning of the reading the radiograph that you go sequentially. So
I
sequentially,
think
I have
it's
also marked the thing for your understanding. You see how much the talus has been shifted. What is
someone
the
has written ankle dislocation, SM. Can you specify? He has written in the chat box. Okay.
okay? So this sort of ankle X-ray we regularly see in the casualty or the emergency department, and obviously we will definitely ask for the whole length of the limb, but for the sake of just the discussion, I have put this much of this thing. So anybody can, just don't be afraid. Just tell me one by one the findings that you are seeing in this part of the X-ray radiograph.
Yeah, I think you should go step by step. If you look at this X-ray, what do you see? Okay, simple as that. You start
Yes,
with
step by step.
AP and lateral X-ray of the ankle. Okay, in the AP X-ray, I can see this. Okay, now you can decide. So what are there? Can you see a fibular fracture?
Sir, we see the lateral malleolar fracture
Fibula,
and
yeah,
subluxation
fracture
of
of
the
the fibula.
talotibial.
There's a fibula fracture.
Yes, and subluxation of the talotibial joints and syndesmotic injury also.
Talotibular joints. What is that? What is,
You are mentioning the tibiotalar joint.
please be clear about your words, huh? Don't just blindly say things. Okay, so what do you see? Medial, what about the medial clear space? What's the normal medial clear space? What is normal?
Due to the
4
space is
mm,
increased.
4, 5.
Yes.
Up to 4 millimeters is considered normal. How much is
Yes,
this?
yes. So you must remember that what is the normal clear space on the medial side, and if you see the next day how the normal ankle looks, this is like everything is it's smooth like this, and then always you have to check whenever you write an X-ray for your ankle injury, you don't write like your APL lateral, you also write the Mortis view, so that you don't miss this syndesmotic injury. So I am not going into the detailed classification of how the leg Hansen classification goes, because that is the basic of understanding of the ankle fractures. And don't somebody told that this is a posterior malleolar fracture, then if you tell in the exam, then you will be in problem, because you see the most obvious thing which is there is the fracture of your distal fibula. You see. Then the second obvious thing is the clear space on the medial side. Third obvious space is this gap in the
Syndesmotic.
syndesmosis. Then you go into the lateral side. Then you see probably there is a hairline crack on the AP. So probably there might be a fracture of the posterior, which is not very well seen in the lateral. And then probably if the examiner goes to ask you what you will do, what you will do now, what is the basic, suppose somebody has come into your casualty with this X-ray, fresh injury, just happened half an hour back, what you will do? What you will check and what you will do?
Yes, Rajan, what you used to do? Just
Cylinder traction, we will try to, sir, reduce and then, sir, apply, sir, slab and
Sir,
Yes.
have to check pulse.
yes, sir, DPA.
Yes. We have to check. Whenever there is this sort of injury, definitely check the distal neurovascular. Then, as because this visual clear space is too much, unless you try to at least get into near anatomy, then what will happen to the soft tissue?
Swelling.
Swelling. Then any fracture there will be swelling.
Blister formation.
Yes, because you see the skin around the ankle is very, very fragile. Okay. So if you don't try to get to near anatomy and immobilize, then problem is that you won't be able to go through that skin in very near future, because there will be necrosis of the skin. Okay. So please read the X-ray of the ankle. This is very commonly given in your exam table. And also please read in detail the classification of as I told you, the trochanteric fracture, all the classification, the Evans, all four prime class, whatever is there up to the Kyle, your Tronjo classification, everything. And in the ankle, you don't forget to read the Langhorne classification. Anybody can volunteer this X-ray? This radiograph, just tell me.
Is tongue type fracture of calcaneum.
Yes.
Is tongue type.
Yes. So if you read this, also the calcaneum, the classification and everything, and in the calcaneum also all the theoretical aspect that will come. I have given for your understanding. This is known as the double density sign, and this is whenever you see this, you know that this is the subtalar part. So this is not in place. Okay. So you see all the Jisan angle and the polar angle. Okay. So now I am coming to this radiograph. Please just now we'll go very quickly. Probably we have understood from this 6-7X the radiographs how we are going to present. Anybody please volunteer what you are saying here?
Is anteroposterior view and lateral view of elbow, and physis is open, so it is of children, and in AP view is similar, but in lateral view there is hairline fracture and posterior fat pads, and so there may be fracture of intra-articular fracture of supracondylar humerus.
No, don't tell like both supracondylar and intra-articular. Okay. So better to if you practice, definitely you will go very smooth. So if you listen to me now, suppose the way you should tell, like this is the radiograph of an immature skeleton showing the part of the elbow, and AP and lateral view where there is a breach in the continuity of the anterior cortex, and also might be breach in the posterior cortex in the lateral view, which is well seen. So this is a supracondylar fracture in an immature skeleton. Okay. So you don't have to justify like open epiphysis and all that. So that you can see that here the physis is all the physis is open and all these things. Yeah, and whenever you read the elbow epiphyseal things, remember the mnemonics when it appears and when it fuse. Okay. So this is another one pediatric X-ray. Can anybody just tell me in short? Now probably we are in proper way how to present the how to tell the radiograph. Anybody, just somebody. Rupam, you can again join. So I think this is the as we have already discussed during the supracondylar discussion. This is an AP radiograph of the proximal humerus showing part of the shoulder, where I can find that there is a fracture of the proximal. You see, they also have given the arrows over there. You can find that there is a breach in the continuity of the bones, where there is a fracture over here in the proximal part of the humerus. Okay. Yes.
Samanta sir, good evening. It's Vishal Mishra.
Yes.
I just wanted to add something. Kindly tell this students how to see the AP and lateral view of the proximal humerus, because in the exam we have seen mostly they are unable to find out which is the AP view and which is the lateral view in for the humerus.
No, in AP view I think this is not the big problem if you regularly see the AP X-ray and the lateral film of the humerus, because you see how the scapula and how the joint is overlapping. You see, if you the classic AP view of the shoulder is not like shooting exactly from the front. It is 30-degree oblique, so that you have a clear space on the front. Clear space between the glenoid and the humeral head. Actually, it is because you know that the scapula is 30-degree oblique. So the beam has to be 30-degree oblique so that you find clear space in between the glenoid and the humeral. That is the true AP view of the shoulder joint. Then there is no like lateral view of the shoulder. That the X-ray that you take, the lateral is the scapular Y view. Another one is the axillary view. I think the axillary view in a traumatic situation nowadays we don't ask for, because in the radiology department the technician will take the X-ray this way, the hand, arm this way, that way. We don't need it. In the pouch itself, if you write the AP and the scapular Y view, then I will show you the scapular Y view in the discussion later, because then you can understand which is the proper AP view and the lateral view. Okay. Then anybody?
Yes. Someone please explain. I think Malik.
So this is a lateral view of wrist joint showing lunate dislocated volar side.
What is it?
I will give you the hint. One, suppose if you see this sort of X-ray lateral view of you have to tell, like I told you the protocol. This is the radiograph of the wrist joint of a machioskeleton. Tell like this. Always practice like this way for the once you pass out, whatever you can jump on the diagonals. You all write that. But this is like this. Now there are two things that happen to the lunate. One is the classic lunate dislocation. Another one is the perilunate dislocation. So two things that you have to see. So what amongst these two, what is this one?
So lunate dislocation, because the radius, lunate, and capitate should be in line normally in lateral view. Here only lunate is anterior displaced, and radial and capitate are in one line. So this is pure. I think this is pure lunate dislocation.
No, probably
How
you are
do you say
mistaken.
that?
Where is lunate? Yes, sir.
You see that I am giving you the hint. You can see the mouse.
Yes, capitate.
Yes. So where the capitate should be?
Just below the this inferior margin of that semilunar shape is aligned with
the head of this capitate has to be here.
Yeah, yes, sir.
Okay. The head of the capitate has to be here. So what has jumped from the lunate?
Capitate is out from, yes sir, perilunate.
Yes. Now probably you can revise. So there are two things that will happen. One is the lunate dislocation, another was the perilunate dislocation. In the lunate dislocation, probably you will see, you know that sign that it will be like this way. Okay.
Yes.
Down.
And that is the spill cup side, you know that. And here you see your capitate, the head of the capitate is completely out from the lunate. So this is a perilunate dislocation. Then I will give you the one leading question. Suppose there is a lunate dislocation. What is the first thing that we will check in the emergency?
First change.
What is the first thing in the lunate dislocation or wrist or this perilunate dislocation? What is the first thing that you will check in your casualty or emergency?
Okay, so what structure passes near lunate?
As we have checked, as we have asked you during the posterior dislocation of the hip, I am giving this much of hint. So there is a lunate dislocation or a perilunate dislocation. What is the first thing we'll check?
The median nerve injury is there or not?
Yes, very good. So in a lunate dislocation, because it is you know that carpal tunnel is there. So this is the first thing that you have to check is your median nerve. Then you check the vascularity and all this, and whether this is an emergency, yes or no.
Any dislocation is emergency.
Yes. Okay. Very good.
So what is the other important thing that you need to see in these X-rays? So one is the dislocation, the other is there's usually a fracture with it. Okay, where is the fracture?
Okay, that's type of perilunate dislocation.
Read the perilunate dislocation, then you will understand that how you have to read the gilula lines. You have to read you have the greater arc and the lesser arc. Then you have to read and properly the X-ray. This is not because I am showing you the only one view, but if you have to have when you suppose in a wrist and like the ankle, you write the AP lateral and mortis. In the wrist injury, you write the AP lateral and the scaphoid view. Okay, so that you can understand the carpal injuries. So here, if the way Sir is asking that probably there is a crack also there. You can see the line over there, and which can be more evident in the AP view or this classical in the scaphoid view. Then you can understand whether whether we are having associated injury along with the perilunate dislocation. Okay. So I am giving you the hint. This is 55-year lady who had a distal radius fracture, and she was managed with manipulation under anesthesia, and below elbow cast was there for 6 weeks, and 3 months time she has come with swollen stiff hand with this X-ray.
I think we'll start with Rajan. Rajan, just tell what you're thinking after this much of history. Yes, Rajan?
What do you see on the X-ray?
So, X-ray left wrist AP view, and
Okay.
there are radial senses and the radial asteroid and ulnar asteroid fracture.
So he's already given you some background of the case.
The pardon, sir, but
What?
I could not listen, sir, that the history.
Giving a small history. 55-year lady, distal radius fracture. As you told you, you can also identify the ulnar styloid injury. And she was immobilized after manipulation for 6 weeks in cast below elbow. And now she has come with swelling, stiffness of finger with this X-ray. What?
So this is a
Can I
classical diagnosis. You
guess?
should not even think about
Can I
it.
guess?
You don't
No,
need
no,
to
there is
guess.
case you
You
have to
You
answer.
should know.
Sudex osteodystrophy.
Yes.
Sudex is no. Sudex osteodystrophy is a term which is no longer used. What do
Yeah.
you call it?
Complex regional pain syndrome.
CRPS.
Yeah, CRPS.
CRPS.
Which type 1 or 2?
Sir, I think type 1, type 2 without nerve injury.
Yes. So Sudex osteodystrophy is the older terminology that probably we used to have during our PG days. Nowadays, we have to tell like the
Chronic regional
CRPS 1 and
pain
2. This is more. It is, if it is associated with the neural injury, then it comes into the category of 1, or else it will come into the category of the CRPS 2. Okay. So because I have given you the every hint was that was possible.
So what you find on the X-ray is a patchy osteoporosis. Okay.
Yes. So don't jump into the diagnosis. You can see from this X-ray, if you see the base of your metacarpals, you see all the carpals, and you see the parts in the distal radius in the alla. There is patchy osteopenia and the destruction of bone. Can you see that? This sort of picture you will only find in CRPS. Okay. So once you see this X-ray, you will never forget in life. Anybody please volunteer this X-ray. Describe the X-ray. Don't jump into the diagnosis.
This is radiograph. AP view of pelvis with both hip joint of immature skeleton, showing dislocation of the left hip, probably DDS.
I told you that don't never use any of the formats.
Developmental dysplasia of hip of congenital dysplasia of the.
You can mention the site. Probably even the X-ray is not been given in the flip manner, so you can mention the site. So so you are absolutely correct. So this is the X-ray of the immature skeleton and showing both hips with proximal part of the femur, and there is developmental dysplasia of hip of the left side. Okay. So can you tell me what are the basic 2 lines drawn in this X-ray to find where is the femoral head?
So Hilgren's line.
Hilgren's line. ये कौन सा है?
Hilgen-Raynaud's line, sir.
Hilgen-Raynaud's
line. Okay.
So I am giving you the hint this way. Suppose you draw a line from this area, the triradiate cartilage this way, the horizontal line, which is the line called, what is the line called?
Hilgen-Raynaud's line.
Yes. So remember like H for H for H. So you will never forget. Horizontal line is the Hilgen-Raynaud lines. Another one line, which is the name of that line?
Perkins line.
Perkins line.
So this is the line drawn from this way. You know that?
Lateral border of.
So that is the vertical line. Okay.
Vertical line and perpendicular to X line.
So where the head should be?
Below, inferior and medial to quadrant of that crossing of line.
Yes, very good. So remember in your Viva table, you will be definitely asked for these 2 lines once you see the developmental dysplasia of the hip. Okay. So this is another one. This was traumatic. So you can obviously tell that this is I told you that this was a traumatic one. Okay. Anybody? I think Dr. Jasbir is on with the mic. Jasbir is already there. Dr. Jasbir, can you join?
Yes, sir.
Tell me. Suppose you are given in the exam this radiograph. How will present the radiograph?
So this is a plain radiograph of skeletal.
I told you I don't have to tell like plain. You're a radiograph.
Diagram of.
This is the radiograph of
Radiograph of
Pelvis.
pelvis with bilateral hip
In
joint.
in a immature
I
skeleton.
told you the mature and immature that you
Of immature skeleton.
okay. So then you have to tell the what has happened to the this hip. You see the hip that we have discussed just now, that was the developmental dysplasia. Here the hip is in place. So what has happened to the left hip?
Lateralization of the femoral head.
What?
Yes, we tell one by one. So you don't jump from, suppose you don't jump from one to the other. Okay. So what has happened to?
Got lateral subluxation of the femoral head.
Necrosis of the femoral head.
Epiphysis of the
So what has happened to it? Can you compare it to the other side and tell us?
Sir, necrosis of the femoral head causing absorption.
Is that what happens in
The
necrosis?
joint space is increased on affected side, sir, because.
So what are you seeing on the X-ray? What you see? Flattening and sclerosis of the capitular epiphysis. Okay.
Head.
Yeah, and you have a fragmentation.
Osteonecrosis.
So you don't go to osteonecrosis straight away. You go step by step, describe the X-ray, and then talk about your diagnosis. Okay.
Yes, the basic protocol, I think you have to follow that. If you compare the other side, now you will understand, as John sir is telling, you see the other side, the volume of the epiphyseal part. You see now you can see. Then there is, if you see the epiphyseal line, whether this is horizontal or whether it is how it is oriented, and you see there is a fragment, there is also the fragmentation, and also this you can see this is not matching with this part, and what are why I have given this. Then please don't jump into the diagnosis during your Viva. Don't tell like this is the Parthes disease of the left hip. That is a problem. Okay. So always try to explain the X-ray. Then I told you this is immature and immature. Then you try to find out what are the findings in this thing. Then finally you can go into the diagnosis. Okay.
And let the examiner ask you the diagnosis. Okay.
Yes, let the examiner ask you the diagnosis. You tell what are the findings is there. What are the findings you find? Okay. So you see also the fragmentation and lateralization. Or this is a spot diagnosis. Anybody just spot diagnosis?
Calcaneum fracture.
What?
Severe disease.
This is a fracture. Come on.
Sir, severe disease.
Severe disease.
Severe disease. Severe disease. Okay.
Severe disease.
Okay. Okay.
Severe disease.
Read all this sort of thing, the Freeberg and all this.
So someone's written shivers. That's not shivers. That's not
Severs. SEVERS. Severs disease.
Yes. The spelling should be correct. Okay. So ankle series I have the thing was somebody was asking for the lateral view or the scapular view. What is the importance of how it is taken? This is just you don't have to take the classic axillary view which we used to order for, but that is absolutely not necessary for your seeing this is just like the orthogonal view and easily taken with comfort without moving the arm. Even the arm is in the arm pouch, you can take the scapular Y view. This is this classic view how the scapula, you can see that the scapula will look like the Y separate. And now with this film, you can diagnose even whether something has happened to the humeral head. And this is the way how you can even find your dislocation. You don't have to have the classic axillary view to diagnose whether the head is gone into the front or back. What is the diagnosis? Anybody please join. Tell me explain the radiograph and tell me if something has happened to the head or it is normal.
Posterior dislocation. Shoulder.
Yes, very good. So, very good. So you will not, told you that you don't dump in the diagnosis. You will say
Light
that.
bulb sign.
Yes, yes.
Left shoulder.
Because
Shoulder joint.
so
Left shoulder joint. AP view.
in appearing the exam, there is also the trick is that you just go slow, let the examiner ask you the question one by one. Don't tell like this is a posterior dislocation of the shoulder with light bulb sign. This is not the way. You follow the protocol every time you see the X-ray. You will tell this is the X-ray, which the side is not mentioned. This is a radiograph of the shoulder joint, showing this shoulder, and the head as not looking normal, and my diagnosis will be like it is a posterior dislocation here, the shoulder. Okay. The light bulb sign, they let the examiner will ask you. Okay.
So you can say that the shape of the shoulder does not look like it is a true AP X-ray. Huh?
Yes.
It does not look like it's an AP X-ray. Although the scapula is showing an AP view, the head looks like it's not an AP X-ray.
Yes, very good. So the thing is that I just give you this next question. The examiner will ask you how clinically in an emergency with a shoulder injury, you will suspect that he might have a shoulder posterior dislocation of the shoulder in one test, one line.
So history, electric shock injury or epileptic.
No. That is the history. Just give me one sign, one test in the emergency without hurting the patient, that you can suspect that there might be a posterior dislocation, because every time you are not going to get the axillary view. I told you it is a big no in current trauma series. Okay.
So we'll compare both side and it will be depressed on the straight dislocated side.
One thing is
The position
over area of axillary regimental beds.
your voice is probably cracking somewhere. So in the obviously there will be trauma and the electrical shock, the epileptic patients, they will be having. One thing is in the posterior dislocation of the shoulder. If you find that there is loss of external rotation, you will suspect that he might be having the posterior dislocation of the shoulder. Okay, remember that. You don't have to abduct. You just check in 0-degree adduction. You just try to rotate, and it will be extremely painful.
Yes, sir. So I think for the next class we'll do all the tumors if possible, sir.
I have a whole series of tumor we can discuss with the tumor. Just when you tell me to stop, I will stop.
Yes, sir. It's already. I think we are.
We'll finish
reaching.
we'll finish this with this final one. The another one class will be doing only on tumors. Okay.
Yes, sir.
And now after this thing, the concluding remark from John sir, then we'll finish. Okay. Anybody please join in this?
So this is anterior-posterior view of pelvic with both hips of skeletally mature patient, showing both hips, proximal femur, and there is left-sided hip joint destruction. There is decrease in joint space plus deformation of femoral head. There is multiple cystic areas in the head.
arthritic changes.
The sclerosis of the femoral head.
Yes, sir.
Okay, very good. So I think our purpose of taking the meeting was successful, that now you can explain how to present your X-ray in your Viva table, that this is the radiograph of the mature skeleton showing pelvis with both hips. Now you describe one by one what you are seeing in the femoral side, also in the acetabular side, and you just explain and stop there. The examiner, let the examiner ask you the diagnosis. Then once you diagnose, then probably he will ask you the the scoring and the grading system. Okay. Don't tell like this. that this is a grade 4 avian. Like you don't never use these. I told you the abbreviations, avians and all this. Okay. So I think we'll stop here as because Dr. Janki has already told me that probably in the next class we'll be taking the tumors. John sir, your concluding remark and anything to add on?
No, that was very good in terms of what people should be learning. I think what is clear that now hopefully they know how they should present an X-ray once they are given that in the exam. So you don't start going straight to the diagnosis. Explain what you see in terms of what X-ray it is, whether you think it's a mature skeleton or an immature skeleton. Describe the findings that you see and only then talk about the diagnosis, and generally wait for the examiner to ask you the diagnosis. So you give all your descriptions and then you can say, I think this is most likely such and such, but usually by then the examiner will ask you, okay, what do you think is the diagnosis? Okay. So I think this is important, and I think Samanta has elaborated it really well and with a lot of examples. So you should be able to answer the different X-rays that you're likely to have during your Viva clearly and with confidence. Okay. So that's the other thing. If you don't know the diagnosis also, you can start describing the X-ray. Okay, you may have no clue about what the diagnosis is, but at least you'll get marks for describing what you see on the X-ray. And the thought process when you're describing the X-ray will kind of lead you to the diagnosis.
Okay, I think, John sir, with the way we have traveled through the reading the radiology, I think if they follow this thing, the great word from John sir, you might not be, the examiner is not expecting every time that even mostly in the tumor situation also, you don't, most of the time you won't be able to diagnose unless and otherwise a clear-cut tumor. But you have to follow in the next tumor class, I will tell you how to read from the inside to out or outside to in. So thank you very much, John sir, for giving me the opportunity to present this one.
Thank you. It's a pleasure. Thank you very much. And until next time, bye. Bye to everybody.
Okay. Bye-bye.
Thank you, sir.
Bye.
Thank you very much, sir. It was great, sir.
Thank you, sir.
Thank you. Thank you.
Thank you so much.